The following is a production of Spark Study Club. To see the full video presentation and receive 1 CE credit, please visit sparkstudyclub.com and register for your free account today.
Hi everyone, I'm Adrienne Good with Spark Study Club. Welcome to this educational presentation and Q&A titled Early Detection, Better Outcomes, Integrated AI and Light-Based Imaging for Non-Invasive Caries Management with Dr. Joshua Solomon. Before we begin, I do have an important announcement about how to receive your 1 PACE CE credit for this webinar. About 1 hour after we've wrapped up here, you'll receive an email to access this course module on our site, which includes the recording and a survey. Please complete the survey to receive your CE certificate. If you have any questions, you can reach out to us by email, support@sparkstudyclub.com, or by clicking Contact Us on our website. A special thank you to the sponsors for this webinar, which is Vivardis, a Swiss medical technology company dedicated to advancing oral health with non-invasive biomimetic solutions that help dental professionals treat early tooth decay and protect enamel without drilling or pain. Cavo, a long-established dental technology company known for developing instruments, equipment, and diagnostic solutions used across modern dentistry. And Pearl, a dental technology company focused on applying artificial intelligence to improve diagnostic accuracy and practice performance. Lastly, I want to remind everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. Okay, so I'm going to introduce our speaker, which is Dr. Joshua Solomon. He is a second-generation pediatric dentist and has been in practice in Livermore, California for 23 years. He's a graduate of the University of Pacific for the School of Dentistry. Following dental school, Dr. Solomon completed an additional 2-year specialty residency at the University of Texas Dental Branch, Houston, and a master's program in conjunction with the Department of Oral Biomaterials. He is a diplomat of the American Board of Pediatric Dentistry and a fellow of the American College of Pediatric Dentistry. When he's not treating patients in his office, Dr. Josh is an internationally recognized speaker and a clinical instructor. Dr. Solomon is the owner and director of the BioClear Pediatric Learning Center and the Specialty Training Center. Thank you so much for joining us, Dr. Solomon. I will turn this over to you so everyone can learn more about integrating AI and light-based imaging for non-invasive caries management. I'm excited. I'll go ahead and turn my camera.
It's a long title. All right.
It's long, but it's good.
All right. Thank you, everybody. I know what busy lives we all have in dentistry and outside of dentistry. So I'm always grateful that people take the time out of your schedules, both in your practice and your personal lives, to listen to education experiences like this. And I want to thank Spark Study Club for asking me to do this. Tonight, whenever you're watching this, my goal for you, my overall goal is I want to change the way that we think about diagnostics first and foremost. There was a time I remember during dental school where I had to get my patient ready for the board, right? And they said, okay, here's the carious lesion, needs to be this perfect triangle right to the dent, and that's the ideal lesion. And I just thought about this the other day on my drive home, and I thought, that was standard of care at that time, right? You look at a little radiograph on a little paper, you put on a light box, and you need to see that triangle to the dent, and that's when you would treat things, right? That is such an antithesis of what I do today and what I would want for my own mouth. I don't want my dentist waiting until I have a lesion to the dent and just tell me that, well, they've got to now make a big hole to get to the small hole in my tooth. So the idea of early detection using technology and non-invasive caries management is so important to me because I spend so much of my time teaching dentists, pediatric specialists, general dentists, prosthodontists. These days, I mostly teach peds, but I love teaching everybody. But if I can help you understand how to accurately and early on diagnose caries and how to treat caries without picking up a handpiece, my job is done. So I'm very, very excited to present all of this to you today. And if you have any questions, I'm reachable. You can ask questions live. But I just want to thank everybody for our time. So the webinar today, we are going to marry 2 kind of subjects together. One is the diagnostics And gone are the days, like I said, we're looking at a light box and we're squinting and our parents squinting and looking for these little shades of gray, right? We have come light years from that. So we're going to marry diagnostics and finding caries early, detecting early, being able to grade decay early, and using minimally invasive methods to treat those teeth. If I could not pick up a handpiece again and perform minimally invasive dentistry and treat teeth early when the decay process is just happening to the tooth, I would love it. Now, I know that's not, at least today, that's going to happen. But my hope is every generation of dentists that come out of school and continue to practice, they can be more minimally invasive. We can spend more time in education and stop drilling holes in teeth. Okay. So we're going to use AI to help accurately diagnose. And the other key concept I want you to understand is AI caries detection is as important as a diagnostic tool as a communicative tool. And we're going to learn how to take all this information from AI caries detection and light-based transmission and fluorescence and how to use that to come up with an accurate diagnostic and be able to communicate that to our patients. And then, as importantly, I want to show you really the newest, although the technology and the molecules have been around for quite a long time in the literature, but it has just exploded in popularity now, is how do we use that diagnostic information to treat teeth early and not drill holes in teeth anymore. I would absolutely love that. So what are some of our learning objectives today? We're going to see how AI-assisted radiographic analysis improves our ability to detect caries accurately. The way that I like to use that, AI gets thrown around for everything now, right? But I really see it as an automated interpretation. That's the acronym that I use because it helps me on a consistent basis not only see, yes, there's cavities, there's caries, or how has it changed over time and have an actual number, a graded number. Is it in 100% enamel? Is it 90% enamel? Be able to diagnose and track over time. And that's a big deal. And we want to look at differences between multiple technologies, both radiographic and using near infrared transillumination and fluorescence. So hopefully tonight and I think most of you are going to see things that are completely new, that are just not part of what you learned, and they're going to add to your ability to diagnose. And we're going to see with these early lesions in enamel, how we treat them efficiently and effectively. We're going to talk about using different medicaments to treat that caries process early. I want us to stop thinking about cavity as a whole, but think about it as the disease process of caries. I want to reduce that amount of acid in the mouth. I want to reduce the amount of bacterial ingress into teeth in the entire mouth. I don't want to just treat one tooth anymore. I want to improve that patient's complete total oral health. And I need to be able to track these lesions over time. So if I decide I don't need to treat something today, in 6 months, do I have, effective means of diagnosing and recording and tracking that treatment over time? So just a little bit of some disclaimers here. I think it's always important as a speaker that I'm completely honest and open with everything having to do with the webinar today. So I was given an honorarium to speak, and you'll see 3 companies down there: Cavo, Curodont, the Vivardis, and Pearl. They did provide an honorarium, but I will tell you that I do quite a bit of work with these companies. I don't even ask if there's an honorarium involved with things anymore because I'm so passionate on using all 3 of these products in my practice. And my overall pledge to everyone that watches these is I do not talk about a product or procedure or anything in dentistry unless I use it every single day in my practice. So all of you that are on here today, with a little bit of notice, you got to give me notice ahead of time, but you're welcome to come to my practice, and you'll see my office here in a minute, and you can open every single drawer. And when I teach hands-on courses, I offer people to open up all the drawers, and you will see anything I talk about is I use on a daily basis in my practice. These are things that I'm passionate about because I use them. And I'm open for all the companies that I do work with. Some of the slides tonight are slides of my patients. Some of them are slides that I've asked for because they just describe the technology, and I don't own Cavo, so I can't make all those slides up myself. All right. And I do own a dental teaching center. And my goal really as an educator is I want to take all this information from different companies and different procedures and boil that down to make it easy and prescriptive for all my fellow dentists. So hopefully we'll be able to do that with you today. Just a little bit about myself and my office. I'm going to take a quick drink. Thank you. So I'm a second generation pediatric dentist. I took over the practice from my father, who just retired about 11 years ago. And I was very lucky to walk into a very busy practice, multiple locations. Since then, like most of us, I moved 3 times. And 2.5 years ago, I moved into my new facility. And we moved into 6,000 square feet, 13 ops with an integrated teaching center. So these days, I spend about 65, 70% of my time in the practice. And all the rest of the time, I'm either giving webinars or hands-on courses or traveling. I think this month I'm away every single week. And I love being a dental educator. I am available to you. So on the upper right there's a QR code you can scan that'll give you my phone number, all my contact information. Also, I'm Joshua at pediatricdds.com. There's my email address. You can go to pediatricdds.com and get more information as well. If you reach out to me, I promise I will get back to you. I typically get a fair amount of emails or calls or Zoom requests a day. So just reach out to me and give me a day or two. If you don't hear back from me, please follow up and remind me that I need to call you back. So just a little bit more about me. I do run the BioClear Pediatric Training Center. BioClear is not a small company. All of the adult courses, all the courses for general dentists and prosthodontists, different specialist endodontists are taught in Tacoma, and that's the home base for the company. And I run the other BioClear Center in the US, which is mainly for pediatrics, and then BioClear is in multiple sites. Just helped my dear friend get rolling there for courses in Iraq. It's amazing the growth of this company over the years. So that's my office. And as I said, we just moved into this facility, and I was really able for many years of my career, 20 years, think about what I want to, how I want to build. So I got an open shell, and I wanted to keep everything light and bright. I do treat patients anywhere from 0 to, I do treat some adults, not too many, but usually about 25 or so is when we cap things off. So I do see quite a few young adults. So I wanted to keep everything open and professional. We have a lot of people come through. I wanted everyone to feel comfortable. And make it almost like in the front, where it's almost like a coffee shop where people are comfortable and parents can sit and get some work done, where their children and teens are having dentistry with their kids in the back. When I teach courses, we convert the office into a learning center. That's a microscope there. Yes, you can use microscopes in 3 and 4-year-olds. I do it all the time. So we convert the office over, and we have dentists from flyover US and Canada. And we've had dentists actually from all over the world come and visit us. I love dental photography. We're not going to talk about that today, but I do quite a bit of aesthetic dentistry in the anterior for teens. And photography has really helped me to elevate my my clinical skills, because it's one thing seeing it a person, but then having a big photo on a big screen really keeps you honest. Here's some examples of just the restorative dentistry that I teach. I try to get teeth to look like teeth. I know that sounds funny, but in the posterior, not so easy with a metal matrix. I've not used a metal matrix for a long time, so I teach a lot of direct composite anterior, posterior, primary and permanent teeth. A lot of what I do is treat class 2s. I would say a majority of my teaching over the last 10 years has been teaching dentists how to diagnose and to treat class 2 lesions, and to make their composites actually look like teeth, to have a contact at the junction and occlusal middle third, to learn how to treat teeth with direct caries management, if you can look at the side of the tooth. These are all the things that I teach. We're not going to talk about restoring teeth today, but it's something I'm equally as passionate about. It's an anterior case, just run-of-the-mill anterior composite using a matrix that's actually shaped like the tooth. And this whole tooth, even to shoot this, took me, I don't know, maybe 15, 20 minutes. So if you have a matrix that's shaped like the tooth, then we can make things really look natural and beautiful. However, for today, I hope to not do this. We are going to talk about accurate diagnosis. We're going to talk about treating caries before they become holes. So if I could go my whole career and not have to do this, great. Unfortunately, I think I still have time left in dentistry, maybe a good another 20 years, and I'm going to be drilling teeth. I do spend a lot of my time talking about prep design in the posterior, especially occlusals in class 2. This is a line of burrs that after 5 years, I work with Dr. Clark. These are finally released on the market. Again, if I don't have to drill holes in teeth, or I can use a new fissurotomy burr and only open up just those enamel grooves. And if I'm able to diagnose that early, great. But today we're really going to focus on not having to take a burr to a tooth. I would like to change the lexicon that we have used in dentistry for a long time. And this is so important to me because if I had a room of new dentists, I would love to just grab them and say, let's try to be minimally invasive. What does that even mean? Let's try to not drill holes in teeth. We're going to have to, but if we can get our patients early, especially as a pediatric dentist, I see patients early and I see them often. And it's my job often to be that first clinician into that tooth. And I don't want to make a big hole to get down to that small hole. I want to practice as minimally invasive as possible, but I want us to understand what those terms mean, because 20 years ago, in my opinion, minimally invasive dentistry meant something different than it did today. So here's the question that I want to ask you at home or at your offices or the car, wherever you're watching this, right? Is prepping a tooth really considered minimally invasive today? It was 20 years ago. We just took smaller burrs and you made smaller preps designs, and we used maybe a GI or a flowable composite, and we drilled smaller holes in teeth. But today, is preparing a tooth, taking a burr to a tooth, is that really considered minimally invasive? So what is minimally invasive dentistry? You know, I went back to the literature, what I do often when I need to get a baseline of really what has occurred in dentistry. And this is back not that long ago, but 2003. This is a great article by Erickson, and he discusses here, you know, minimally invasive dentistry is a concept that can embrace all aspects of the profession. The common delineator is tissue preservation, preferably by preventing disease from occurring and intercepting its progress. That's a big deal. That's a big deal. What is he saying here? What he's saying is he wants to preserve tissue. There is a biological cost every time we have to drill into a tooth. Now, there's a cost for the dentist to buy materials. There's a monetary cost for the patients to pay for things. But as importantly, or more importantly, there's a biological cost every time I take a rotary instrument and I touch a tooth, right? I have to take natural, healthy tooth away to treat that carious lesion. And if I can prevent that from happening, then I really have done everything I can as a pediatric dentist or as a clinician who really tries to preserve tooth structure as much as possible. So in this article, I think there's 3 points here that are very important. So he talks about early detection. That's going to be half the webinar today. How do we detect earlier than when we can see with our naked eye, right? And then how do we leverage technology? We need technology to do this. Again, those days of looking at a light box in a little gray spot, or our eyes only see about 30 to 40 scales of gray that goes down over time. So we're going to use technology not to do the work for us, but to detect early and to help communicate that to our patients. And as importantly, the part B of the webinar today is remineralize. How do we take just something from a bottle or a package and a brush, apply that to the tooth, stop that carious process in the tooth at bay, or even better, remineralize and add back what was lost to that tooth. When I started dentistry and we said patients that had watches, it was, well, good luck, work on flossing, maybe, use a little varnish or a mouth ornaments, floss really well, and let's check you in 6 months. We weren't doing anything to actually repair that tooth. And that is a big sea change today. So here's another important concept that I really want everyone to understand, and write this down so you have it in your brain when you get back to the offices, is this idea of chemotherapeutic management of teeth versus a microsurgical event. What does that mean? So chemotherapeutic means that we're using a chemical or compound to provide treatment to that tooth. Then classic dentistry, even if we're using small burrs, is microsurgical management of caries. We actually take a rotary instrument or air abrasion and we're cutting holes in teeth. And that's the distinction. Burr, I just thought of this last night. Late at night, couldn't sleep, and I was thinking about this. Brush or burr. That's an easy way to think about things. Am I going to take a medicament out of a package, out of a container, use a brush to apply it to the tooth, or do I need to treat it with a burr? If it's a burr, I don't consider that minimally invasive. Now, can I use principles of minimally invasive dentistry using the correct burr shape, using smaller prep designs, addressing caries early before it gets down to the dentin or to the pulp? Yes. But the second that I need to pick up a burr, the concept of true minimally invasive dentistry really goes away. There's just some important points here. I do want everyone to change the lexicon, right? We can't change hearts and minds with our staff, with our colleagues, unless we change the words that we use. And so this term minimally invasive dentistry, I want you to really get that in your lexicon and start thinking about what things can I do, prevent or treat, without the patients having to go through getting numb or having to drill through teeth or sitting there for 2 hours, right? I want to get rid of this concept of drilling smaller holes in teeth. If we take a burr, then we start that death cycle of the tooth, right? When I was in dental school, we learned this whole idea of, watches, right? Is this a watch? Is it a treatment? Is a watch? Unfortunately, what happens, and I see this with children sometimes who are not, always the most cooperative, there can be supervised neglect. Are we just seeing changes in radiograph? Yeah, we're going to watch it, right? Well, sometimes that's a great idea, right? You can't, even if you've arrested decay, you can't always see a change right away in the radiograph. It's not going to necessarily recalcify. Now, sometimes it can, depending on what products we use. But what I don't want to do is just wait, and then wait till caries get to the DEJ, and then start drilling holes in teeth. Unfortunately, there's a lot of supervised neglect that occurs just because I don't think dentists are doing it on purpose. Is they're not understanding there are tools and there are medicaments out there. There are instrumentation to diagnose, communicate, and then new medicaments that we place on teeth to help treat that carious lesion before it becomes something where we need to drill into. So let's put that term watch away. Now, I'm not saying don't ever watch teeth. What I'm saying is let's change that lexicon, thinking about what can I do to actually stop that carious process, right? And what are the difficulties as clinicians, practicing like this, right? Number one is we didn't have the technology. Again, if we're just looking at a radiograph on a light box or a standard digital x-ray, sometimes caries are hard to see. We get busy, we miss things. But also we need to be able to have our patients understand, well, these things the doctor is recommending me are important. I have a disease process going on in my tooth. I better come back and follow through with the treatment plan that doctor prescribes, right? Just because we can diagnose early doesn't mean that we can do it consistently, right? Sometimes the radiograph's turned a little bit, it's underexposed. Sometimes we just can't see. And I need everything in my practice to be accurate and repeatable. And pediatrics say, we may see 50, 60, 70 patients a day if myself an associate. So it needs to be accurate, not just once, but that patient number 1 and that patient number 70 at the end of the day. So as much as possible, I want to take human error out of that. Now, we are still human, but if I can leverage technology to help me increase both my diagnostic acumen and my repeatability, then everybody wins, right? And I want everyone on the webinar to really understand in depth all these minimally invasive treatments, these chemotherapeutic treatments that I'm going to discuss with you. Because I find if you really understand the concepts, you're not going to feel like you're just selling something, right? If you have a new, liquid that you can put on the tooth and it only takes you a few minutes, sometimes I feel like if we don't understand the technology, it's just an upsell. Well, we'll put something in your teeth, it'll get better. No, I want you to truly believe in what you're doing, and the use of those medicaments will be greater in your practice, and you'll be able to speak with enthusiasm. I'll give you a case in point with Curodont. I placed it on all 3 of my girls. Maybe they weren't flossing as well as I thought they were, and they have some interproximal lesions, and they all have Curodont, every single one of them, a few of them on their anterior as well, all of them. I wouldn't put that on my own children if I didn't believe in it, right? And I want my patients to be able to buy in and understand the carious process that's going on with their teeth. And I want you to have resources so you can talk to your staffs about things too, okay? This recording I just saw recently, and it blew me away. I think I've watched this like 6 times now. This professor, I'm going to mispronounce his name, hopefully not, but I think it's Krajewski. I really would love everyone to listen to this. And so I made a QR code here. In this 25-minute video, he discusses that restorations, it's not a cure, it's a repair. We're drilling a hole in the tooth. I'm just going to read these because I think they're so pathetic. Restorative dentistry is not a consequence of caries. It's a consequence of the failure of caries management and prevention. Amazing. Early detection, treatment planning, and patient acceptance is crucial to provide the greatest chance of minimizing destruction of the tooth. If we diagnose early and treat early, we have the highest rate of minimally invasive methods being successful to our patients. And lastly, diagnosis is something extremely important. If you want to change dentistry in the field of caries management, we have to change diagnosis. We have to focus on subclinical appearance of caries, not the clinically evident carious lesions, those holes in the teeth, right? Because the diagnosis comes far too late. And lastly, detect and arrest or even regenerate active non-carious initial carious lesions, no more watch and wait. And that's what we're going to talk about today. We're going to leverage several pieces of technology like DiagnoCam, like the DiagnoDent, like Second Opinion AI caries detection. And we're going to treat those as a diagnostic tool and a communication aid. This is an important concept. If we were able to diagnose early in that, well, I think we all learned this life cycle of death of a tooth. If we are able to diagnose the decay process in a tooth early, in that stage from healthy tooth to just that smallest carious lesion, we have what we call this chemotherapeutic window. If we diagnose early, before we get to caries that get deep into the dentin, we have this small window of time to put a medicament on the tooth, to place a compound or a chemical on the tooth itself to stop that caries process, or even better, stop and regenerate, right? But we only have a small window to do this. And we need technology enabled to do this because you can't do it with the naked eye. Again, I mentioned it earlier, your eye only sees about 30 to 40 levels of gray, whereas a computer is going to see thousands and thousands. I don't want to watch and wait. I want to do something to make things better. I've always used high magnification. I think it's still important using loupes in your practice. We need to have, of course, our naked eye as well. That's part of this. We're not just leveraging technology. I use microscopes in my office. I have for a decade. And so this concept using fluorescence, using light, I've been practicing for a long time. And then I picked up other technology that allow me to do that chairside. I have really three tools that are quintessential in being able to diagnose early and communicate with the patients. Number one is KVO DiagnoCam. Number two is AI caries detection. I use Pearl in my office. And then when needed, using an intraoral scanner. These three tools, these three instruments allow me today to feel like I truly can diagnose early and accurately and be able to communicate with our patients. So there are multiple devices on the market that will do, they'll take photos, of course, right? There are multiple devices that will use the technology of fluorescence to look at the porphyrins and bacteria. And there's some devices that will give you some transillumination. But the reason why I selected the DiagnoCam, and again, I found it on my own a year and a half ago, was it did all three. It's the only device that does all three. And the way it does things is important. So there are, like, per se, some intraoral scanners that will use more of reflection in order to look for caries in the teeth. But the DiagnoCam is a different technology. So it is near infrared transillumination. It's using a light source that is, laser based, that you can't see with your naked eye, to transilluminate through the tooth and to take a photo. And what you see here is absolutely amazing. We're using that transilluminated near visible spectrum light to shine between the teeth and be able to take a picture. It is like a negative, and you can see the carious lesion there just shy of the dentin. Not only am I diagnosing caries yes, caries no, but now I'm seeing where that caries is in the contact itself. If I have to prep this tooth, do I need to prep more buccal, more palatal? Is it in the dentin? Can I even see it on the x-ray? Do I even need an x-ray? So the ability to change the way we diagnose and diagnose early is a sea change of what we were able to do before. So here's the device. It's shaped like a similar intraoral camera, has some buttons on it, and these are the fiber optic tips when we use this in transillumination mode. So this is really a 3-in-1 device. So it's giving us a standard intraoral photograph, an HD photograph there. It's using transillumination, again, to highlight the areas of active decay, and then fluorescence to look for active decay and assign that to a color, and then transillumination to actually be able to see between the teeth. So one click of a button, I'm getting all three images here, right? So this is that near infrared transillumination. It's using near infrared light, shine between the teeth, and take a photo. At the core principle, It's pretty basic. Shine light through, make it look like a negative, take a photo. Now, the technology itself is not basic. So I'm going to design all this and put it, in an easy to use device. But the concept for patients to understand, when I show them this, I tell them it's like a photographic negative. And I can truly see, I'm not using a computer generated image. I can truly see with my own two eyes, and they can see with their own two eyes where that lesion is in the tooth. And that E1, that E2 lesion becomes easier to see. Now, E2 lesions, easier to see, yes, but I'm able to diagnose far earlier than I ever did. And I'm able to take, if the patient wants to come back once a week, and I wouldn't do this, but I can use transillumination. For my young ones that I'm using SDF, I may not be able to get radiographs on that 2 and 3-year-old after the first medicated treatment, or that teenager that I put Curanon on. If I want to come back in 3 months and evaluate, I don't necessarily want to zap them with an X-ray every time, and this is just using light and a photograph. Then we see that the fluorescence there, looking for the porphyrins, and then the standard image. Okay, so it's 3 in 1. And what you'll be able, here's another concept I want everyone to understand. If a lesion, and this is important, if a lesion is going to be detectable on a radiograph, you need to, depending on the study, lose anywhere from 12, 13 to also up to 40% of the mineral loss in the tooth. Okay. So really on x-rays, I think the way to summarize about it, it's really, there are some studies showing it earlier, but it's really 30 to 40%. So you have to lose 30 to 40% of that mineral loss to become radiographically evident. The ship has sailed since then. There's already a fair amount of damage done to that tooth at 30, 40%. So what, and then, visually, we only can see so much, right? You take your explorer, you poke in the tooth, and that's your diagnostic criteria if you need to fill a tooth or not. Not very accurate whatsoever, right? 12 to 50%, sometimes even lower than that. And in my practice, I see majority of my caries are class 2. I can't poke into that, right? I either got to take an x-ray, maybe use some air and look around to see, in proximal areas. But I'm going to use all 3 of these technologies together. So what happens with transillumination? We have these fiber optic tips, and it surrounds actually the periodontium there, and that light transluces through the bone and the soft tissue through the roots into the tooth itself. We simply take a picture. I mean, technology is amazing there, but at the core concept, it's just light, and you see a negative, and you can actually see the outline of the decay. So do I need to prep here? Do I need to prep here? Do I not prep at all? Am I already into, the dentin? This allows me to be, to marry that X-ray and now using transillumination and be able to marry those technologies together to diagnose early and be able to communicate with my patients. And, we're not going to have time to go through studies. I can send you whatever you want. I'm happy to. And also these are on Cava's website. But it just shows you that, here, approximately 4 times as many lesions reaching the enamel DJ by comparison to bite wing radiography. So using just light and your 2 eyes in a photo is highly, highly sensitive, and there's no radiation. And we can grade decay, right? Dentists, we love, the ICDAS, we love coding systems like this going all the way to 0 to actually having caries go to the dentin. But if I can, I want to start diagnosing and treating here, that 1 or 2. I don't want to wait till things are 3 or 4 when I'm already into the dentin of the tooth. So not only can we see interproximal decay, we can see occlusal decay, we can see decay that was either not removed in the first place or secondarily from a leaking restoration or with cracks. And let me show you just a progression of lesions here. Okay. So here we have that kind of E1-ish, E2 lesion where we've entered in the enamel, right? And we start seeing decalcification. So that's going to show up more opaque. And then it starts getting larger. So right to the DEJ and then straight into the dentin. And then, a large lesion that's into, maybe close to the pulp at this point. But I have my radiographic and I have an actual photo of the tooth. And for me as a pediatric dentist, I see a lot of special needs patients that there's no way I'd be able to actually take a radiograph and I can get a diagnocam image of their tooth. And I used to just dread sometimes for patients that maybe they were teens and they're not cooperative enough to take x-rays. I just would dread to know what's going on between the teeth because I can't take them to the OR just to take some radiographs unless I think, there's actually some evidence of caries there. For occlusal restorations or occlusal lesions, not only do we use our eyes for that, but we can actually see penetration down deeper into the tooth. So it's really giving us a deeper look into the tooth itself and help us to diagnose early and accurately without exposing that patient to radiographs. Where I find especially our general dentist and prosthodontists love this device is looking for cracks, right? Yes, you can take a CBCT, but to actually be able to see where those cracks are and show your patients is absolutely amazing. This is one thing to show them just a photo, but if they can actually see those cracks here, extending down past the DEJ circumferentially around their teeth, just a photo of this alone to show the patient or to attach to insurance makes a big difference, because the layperson that's looking at this, who's not a dentist and deciding if your patient actually, quote unquote, needs a crown or not, they definitely see the cracks in those teeth, right? I mean, look at that. You can see every little secondary, initial crack secondarily and all the way, undermining cusps, right? Just some examples. I wanted to show you the difference between looking with the naked eye or with magnification, then on the diagnocam itself, and then on the radiographs, right? This is now mirroring all three of those. Our eyes, the X-ray, and AI, for using AI caries detection, and the actual photo of the carious lesion, right? Just some other examples. Now, obviously, if there's a large lesion there, you're going to see it in great detail, sometimes clinically, sometimes not, but look at the difference. The average patient, they see that circle and see, they may say, oh, doc, I see a little shadow there. But without batting an eye, I think most people that are reasonable, we're going to see that image on B and see how that caries is actually entered in its tooth. And again, you have a 3D roadmap. Occlusal is the same way. You show your patient that the photo of A, yeah, there's a little staining there, but they may not be 100% sold. We know that occlusal radiographs are not super accurate unless it's large caries, but look at the transilluminated image there. You see that 3D outline and you really know where the outline of that lesion. Primary teeth here, which I also look at all day, every day. And there's so many of these children that I would not be able to get number C, that I wouldn't be able to get a radiograph. But if you look clinically, looks okay. But then you look at the diagnocan image and you can see the caries there. And I can also see caries early. So if I'm going to use a medicament like SDF, I can treat those teeth early on and not wait till my caries is already to the DEJ where SDF is not effective. So how does this work? It's just an intraoral camera, basically. I mentioned that, earlier about the fluorescence. It says porphyrins in the bacteria that will fluoresce under specialized lighting and that will show. And you just click one button and it's going to pick up all three images. Now, if we're able to marry the radiograph and our clinical examination, now also fluorescence, this is as accurate as it gets. It's going to show us active or restive decay. And it's really going to point out for, especially that patient, they can see, well, this is not just a stain, there's actually decay in the tooth. And this is one of the other big advantages. It's not just diagnosed as us as a clinician or dental professional. The patient has to buy in that this is the right thing for their tooth and want to sign that treatment plan and come back so you can treat them. And I find having tools like this greatly increase my ability to convince my patients that they truly need treatment. And I'm not just, making things up because I want to, place restorations on their teeth. And again, we love clinical guidelines and numbering systems in dentistry. And so here we are marrying that transillumination and the fluorescence itself. And we use that with risk factors and AI caries detection. And now we really have this complete package in being able to diagnose. This example of a patient that was special needs. He was a teen, lives in a home, and I saw this lesion clinically, and there's no way I could get radiographs on him, but you see transillumination, then on the left, the fluorescence, and then what appears in the mouth, and I can truly see into that tooth. The system that Cavo uses is actually I believe the only piece of software yet in my office that's not integrated into my practice management system. I find it's very easy to use. Patient's name goes in, and then we can track, it takes, if we want, we can set it so all three images will appear. We can track this over time. And I won't go into a lot of features here, but you can easily toggle between time points to compare those three images from one time point to another. Very, very easy software to use. You can even track caries here. You can, put in your watches or areas of concern or teeth that you are treating. And this is all in one package altogether. Okay. And again, there's another translated image. All right. So let's switch over and talk about AI in dentistry. And I'm really going to focus on the caries detection component of this, okay? I've been using Pearl AI caries detection for over 2 years in my practice. And just recently, we're not going to talk about voice today, but this has been a game changer. I talk about this on a podcast. The first week I had this, I gave a 20, how long was this? It was a 25-minute consultation. And at the end of that, I would have typed notes, but I clicked a button and I had this entire page of notes in perfect order, perfect spelling. And I just updated that in the chart. I sent it to the parent because the other parent wasn't there. They wanted some more information. It was all there with us. Again, not, the topic of today, but this has completely saved me, I think, at least an hour a day in my practice. So what is second opinion? So second opinion lives in two different areas. There's a standalone version, or for some software, it's integrated into your imaging. If you can, always get it integrated into your imaging. So what this does is it allows us to take that radiograph and almost instantaneously, if I'm using it, let's say in EagleSoft, when we bring up the bite wing, we see the Pearl image there. So this allows me to diagnose and communicate in a much more precise fashion than I did before. I had back in December about a month where there was an upgrade in my dental software and I couldn't use Pearl. And I do not want to practice like that again. I just found it was so much more difficult into describing caries with patients and parents. Our eyes only see 30 to 40, maybe 50 scales of gray, but the AI is looking at thousands. And this is the interface. So not only will it show you caries, it'll show you different tooth parts. It'll show you bone height. It'll show you if there's widened PDLs or if there's possibly evidence of pathology. And this is not the computer taking over your job, right? It is allowing you to diagnose earlier and more accurately. And if you see here, this is going to actually give you that breakdown of caries and enamel versus dentin. Why is that important? So for these chemotherapeutics that we're talking about putting in teeth, it will allow us to grade those over time. Is the caries actually using numeric value? Are we at 100% enamel? Are we at 90% enamel, 10% dentin? So now we have a medical, accurate medical legal record of that caries progression over time. So let's take an image here, and it's a little grainy, probably not the best X-ray possible, but decent. And this is a fun exercise you can pause and at home now. I want you to evaluate how many carious lesions you see here. But then I'm going to turn on second opinion. All right. Now you may have seen a lot of these, but you tell me if your patient's going to see those. If you're trying to explain to them why that they need to have Curidon in their tooth, or why they need to come back to have a standard class 2 composite, I want to be able to show them colors like this, right? And then tooth parts. Amazing. Absolutely amazing. Just reach, as a patient I pulled up, and, this shows caries. I like this because it has lesions in all different depths, both in enamel, then dentin, and then, of course, into the pulp. So this is the standalone version of second opinion, and it will allow you to toggle on or off very easily. All these different options are adding things to this software all the time. Sometimes I will use the standalone, but most of the time I'm using this within EagleSoft. And amazing to show parents. Now they truly understand. Is this enamel? Is this dentin? Or is this into the pulp itself? And just some other examples of, Pearl using in my office. Anterior caries. These were just from yesterday, actually. I pulled them in. I was able to accurately show that parent, okay, here's a lesion on the primary second molars. It's gone from the enamel into the dentin. Now let's look at number 3. We're getting pretty close. This is still going to be a tooth I would treat with Curidon. But not only can I show the parent in that accurate AI-assisted image, but now I can track this over time. Let's say they didn't want to, they said, no, we don't want to do Curidon. We're fine. We're going to allow this to get bigger, and we're going to work on flossing, which a lot of them say they do, but they may not. I'm able to track this over time. Image from yesterday, just grab one at the end of the day. A parent is not going to be able to look at this radiograph in the same detail and understand you are, but they can see that. And I think this is one of the reasons why, besides being able to accurately and hopefully efficiently and speak to parents, communicate in a manner they understand, but ask yourself, do you want to see on the left or do you want to see on the right as a parent? That's where we call this a second opinion. It is another non-biased pair of eyes, allowing my parents and patients to truly see that carious lesion in the tooth. And all the other extras are amazing, right? So if I have a teen that day, let's say the parent's not there, I can send them home with a report. You can make a report here for insurance. You can send, attach radiographs and intraoral photos and give a report like this and send it home. I mentioned Pearl Voice already, and this was the note that I had, and I'm using this every single day now. And I will tell you, without equivocation, it's saving me at least an hour a day of taking notes, because my assistants can only do so much. If I'm talking about general anesthesia or more serious topics, and I need everything written down there without spelling mistakes, in a logical order that I would be happy for anybody to read my chart. This would take me 15, 20 minutes to type. Nope. And there's two options. It was either, at the end of this, there was one option that was the condensed version, and then, a longer version. It gave me both options. I mean, this is absolutely incredible. Looking at radiographic findings and risk assessment. I mean, the AI didn't change what I said. It just organized it in a more complete fashion that could be understood. So lastly, here's a little QR code from Second Opinion. I just wanted to make that available. And one of the things I like about Pearls, there's no contracts, right? So if you use it for a month, you don't like it, which I haven't met anybody that hasn't yet, you can just cancel it. I rarely, as I said, I've never met anybody that started using this with, that didn't say, I'm going to use this every single day in practice. I would not want to work now, just with knowing I'm not going to miss things. I can communicate with my staff. My staff, when they pull up that AI image in Pearl or within, EagleSoft and the Pearl plugin, even if I'm not at the chair yet and they see all the pink and green, they know that, or pink and yellow, they know they need to start getting out the Prevenant or the floss instructions or bringing the parents back. So the efficiency of my practice really has changed. So let's talk about something that I'm equally, absolutely as passionate about is now we're going to talk about treatment. So we're going to change that mindset on diagnosing early. So now we've completed the diagnostic and the communicative part, right? We've been able to observe that carious process early, hopefully even at that E1 lesion, and be able to communicate to our patients that we need to do something about it, right? We're not looking at little grayscale on an x-ray that's on a light box. So we're going to talk about this chemotherapeutic treatment of caries. Remember that brush or burr. We're going to talk about brushes. Let's put the burrs away. So there are 3 products I use in my office every single day. Number 1 is fluoride varnish that most of us use. SDF, I'm passionate about that. I can talk to you an hour about SDF, but we're not going to talk about it today. And we're going to focus on Curodont Repair Fluoride Plus. One concept I want people to understand is, although this may be new to some people, Curodont, the actual molecule that the compound that's used in Repair Plus is not new. That actually, there's literature back to late 90s talking about this, right? But it wasn't for the fact it was in literature for a long time and then finally became available. And now in my practice, we use this on many, many patients a day. White spots, class 2s, all 3 of the practitioners in my office, everybody's using this. And like I said, I've used it on all 3 of my girls. So SDF has really been the standard of care. I use that on primary teeth all day, every day, and I will continue using that to the end of time. But I do want to talk to you about Curodont itself, okay? And one of the magics here of Curodont not only is the efficacious repair of teeth, but this literally takes me 3 minutes a tooth, and I can do it that day. So I can add on that patient. I see that teen that's got 12 suspected areas, or not suspected, 12 areas of that E1, those E1, E2 lesions I picked up in my AI. I can treat that patient that day without having them come back. Because unfortunately, I was a watchodontist for a long time. I saw the caries there. I just saw them getting progressively bigger, but I didn't do anything about that. So what I'd like everyone to do for this last portion is really focus on understanding what Curodont is and why early detection is important, because you're not going to use this in your practice unless you truly believe in it. And it's something, again, that I do. And here's what we're trying to do. I want to be preventative and not just perform supervised neglect. I don't want to just say, well, we're going to watch things get bigger, and then once it gets big enough to the DEJ or for the GJ, we're going to drill a hole in your tooth, right? Nope. We're going to provide treatment. We're going to provide it earlier. We're going to provide that where we're not at the point where we actually have a cavitated lesion. Now, if we have a cavitated lesion, it's okay. It's a certain size, but we're going to be most effective with that E1 lesion when we can. remember that this is an important concept. Fluoride only protects the outer, helps to recalcify the outer surface, correct? So it does not penetrate into the tooth at all. But Curadont's it's a different compound that actually helps to go deeper into that tooth, right? Up to the DEJ, which is pretty amazing. Now, do I want to wait till we get to the DEJ? No. Remember, when you first see that quote unquote watch, 30 to 40% of mineralization is already gone. And this is why having detection early on is important. However, this opens up my ability to treat deeper and deeper lesions because that Curadont actually will perfuse through the enamel into the dentin, and those E1, E2 lesions become treatable. And if I combined all three, transillumination and fluorescence and Curadont, I am providing the most accurate diagnosis and now the most efficacious treatment that's non-invasive. I'm taking a brush instead of a burr. One concept I want people to understand is, I've talked to some docs and said, well, I use Curadont and, the lesions haven't gotten any bigger, but they're still on the radiograph. The important thing for me is now and I see this every day, if I see actually regression of that lesion, right, where we've added more to that enamel matrix and it's reversing the X-ray, great. But most importantly, I want to see it not get bigger. It's the same thing with Curadont we'll talk about in the end here. The goal is not to get rid of the white spot lesion aesthetically. Now, sometimes it does. I can't guarantee that it will, but most importantly, it's repairing it from the subsurface first, right? So what is Curadont? I think that's an important thing for people to understand because they may not know the very basics here. So it's really biomimetic enamel repair of that tooth. And we are using a compound that we put into the tooth to create a scaffold to allow that tooth to heal itself. So although it contains a small amount of fluoride, the whole point of Curadont is to build a scaffold in that decalcified enamel. So the calcium and the phosphorus in that tooth will help to recalcify naturally and strengthen that tooth. So the way it basically works is that it's sensitive to pH. It's thixotrophic, but it will, with the pH is lowered, it will then enter into those enamel tubules. Then the pH will change, and then the viscosity goes from more quote unquote runny to more of a gel form, and it creates that lattice, that matrix, to now allow the fluoride that's in our toothpaste or the fluoride that we apply or the calcium or the phosphorus naturally from the mouth to recalcify that tooth. So it's really as you're just trying to replace or re-provide that scaffolding for the enamel that we lost, the minerals that we lost in the enamel. SDF is not going to do that. SDF is I love it, but it's efficacious for the right lesions, but it's only going to treat the surface. It's not going to penetrate into that E1, E2. So it's that viscosity change when it soaks into the tooth, secondary to the pH, that really now it becomes a lattice or a matrix, and it's allowing that tooth to naturally heal itself. But again, we need to try to diagnose as early as possible because you will see a greater efficacy for those E1, E2 lesions. There is a huge amount of research that's available to all of you. If you go on Bavardis's website, or if you look just even at PubMed, the compound that's used in Curadont actually is discussed in the literature back in the late 90s. And here actually in Nature, one of the most prominent scientific journals here in 2020 is an article about, the P11-4 compound that makes up, it's the majority of what makes up Curadont. And, you've got a meta-analysis, these long-standing systematic reviews of the literature. And it's not just Bavardis' literature. This is in university studies. And you see these long-term follow-ups, right? Baseline, 10 months, 22 months. So what does Curadont look like? They come in these packages, very, very easy to use. I want to show you a video because many people have not even seen what it looks like. It's contained, there's a liquid and a sponge, and you clean the tooth, you add the tooth, and it goes right in. It comes with instruction cards. They make this very, very basic. You open up each one of these individual packages, and it has the step-by-step instructions, even has little videos for you to watch. So it makes this very easy to use. And now it's even easier. So many of you have used Curadont even before 2025, August last year. So the newest generation is they've changed the packaging, they've changed some of the way that we apply this, and you got it down to literally takes me maybe 3 minutes a tooth, if that. Okay, and so what I want you to think about, again, the lexicon's important here. Guided enamel repair through hydroxyapatite formation. We're not just applying fluoride to the surface, we're actually penetrating that matrix into the tooth so we can take those naturally occurring ions or fluoride that we, from toothpaste, from sodium neutral sodium fluoride gel, thank you, to allow a greater uptake of those minerals to heal that tooth naturally. And we're getting much deeper than we did with SDF. And the thing I like about it too, if I have a parent that feels that they want more of a biomimetic, a more natural processing your tooth, we're just reproducing what nature is doing, but we're allowing that scaffolding to form again, to pull those minerals into the tooth itself. Okay. And this is a brush. It's not a burr. And what we can see over time, now we're not always going to get a complete change on the radiograph. We may see a reverse there, but if you don't actually see a reverse in the lesion, that doesn't bother me. What bothers me is it's not getting bigger. Okay. I'm sorry, that makes me happy. If it got bigger, that's a different story. But what I truly want to see is that the lesion has not increased in size. That's the most important. The earlier that you diagnose and the earlier that you place Cured on the tooth, the higher chance that you will have to actually see a change in the radiograph and actually watch reverse. And so I want to show you a video here.
How to apply Curedont Repair Fluoride Plus. This protocol is easy to follow and optimal for same-day integration. Remove 1 Unit A and the pouch containing Unit B from the Curedont Repair Fluoride Plus box. Peel off the cover of Unit A, then retrieve only 1 Unit B. Keep the remaining unused Unit B in the pouch for future use. Pour the entire content of 1 Unit B into the Unit A receptacle containing the sponge, letting it absorb the liquid for at least 2 minutes to fully activate the proprietary formulation. While the sponge is soaking, proceed with preparing the treatment site. Clean the lesion to remove the salivary pellicle. You will then rinse and dry and apply your etch directly to the lesion. If applying to the interproximal area, use unwaxed floss to distribute the etch. Again, rinse and dry very thoroughly. After ensuring that the sponge in Unit A is fully soaked and soft, place cotton rolls and/or dry aids near the treatment site. Now that the treatment site has been thoroughly prepped, you're ready to apply. Grip the sponge from the corner using cotton pliers or hemostat. Press the sponge on or near the lesion to express the formulation for 5 seconds. For an interproximal application, press the sponge on the lingual embrasure for 3 seconds, followed by the buccal embrasure for 2 seconds. 1 fully saturated sponge can treat 1 lesion. 1 lesion is defined as 1 interproximal site involving 1 or both surfaces, 1 occlusal surface, 1 smooth surface, or demineralized white spot lesion. After application, the patient can close and instruct them to not rinse, eat, or drink for 30 minutes. To learn more about Curedont Repair Fluoride Plus, visit vivardis.com.
So just to show you the steps again, here's what you do want to remember is that you need to apply that liquid and let it sit for a minimum of 2 minutes. It can sit longer than that. So when we see our patient, that's typically when my team will open up that package and apply the liquid. And again, we're going to leave that for at least 2 minutes. Okay. So here's the steps. Very, very simple to use. You're going to clean off the tooth. So we want to remove that biofilm, whether you use a particle abrasion or use pumice and just a prophy cup there. But you do want to remove that protein pellicle, all that biofilm off the tooth itself. Then you're going to take your standard etch, that 35% phosphoric etch, and you're going to etch. You don't actually have to inject into the contact there. But each one, it's a class 2 here. You want to inject around that contact and then take some floss and go ahead and floss that contact. This is the only time you're going to use floss. After you apply Curodont, you don't want to floss, but go ahead and floss that etchant into the proximal contact. And you want to make sure that that sponge, again, has been sitting for 2 minutes. You're going to place cotton roll isolation here, or if you use isolate, you can use isolate as well. And all you do is take that sponge here, let's say for interproximal area, and you're going to slightly squeeze on one side, then the contralateral side, and then you're done. Some people place, it's not required to, some people place, fluoride varnish. That's what I do over this area. And then I just advise them not to eat or drink or spit out for half an hour. And then we dismiss. And that's literally it. And that's how easy it is to place Curodont. And this can go anywhere where we have a lesion that we have diagnosed that has begun to decalcify. Again, earlier the better. So E1 is going to be better than E2. I want to discuss smooth surface for a minute. The point of Curodont, Repair Plus, is not to aesthetically reverse white spot lesions. Sometimes it will, right? So that's a bonus. However, we are treating the actual decalcification process. So something I do, unfortunately, very often in my practice is I will place Curodont, then I'll have the patient come back if they work on hygiene, and then I may use something like Icon to address the white spot lesions. So don't feel like you had a failure with Curodont if the white spot lesion does not regress. You are hardening that tooth, you're recalcifying that tooth. And then if you want an aesthetic treatment on top of it, if you didn't get the results that you wanted, fine. So smooth surface, occlusal surfaces, interproximal facials. The other thing I want you to remember is that one sponge is for one treatment site. So back-to-back lesions, fine, but don't try to do, you need to maximize the amount of the compound into that contact. So that 29 to 30 here, that contact, it's going to be 2 teeth, you're going to use 1 sponge. When you go to the next contact, if you're treating multiple, you need to grab another sponge. So you're going to count, you and your team are going to count, we're going to treat 3 treatment sites. So you're going to open up 3 packages, take the liquid out and let it sit on the sponge itself for at least 2 minutes for each one of those sites. So you're going to open up 3 packages itself, okay? You can get a little wet, a little bit of blood, but I would try not to. And it is, you do want to isolate or again with cotton rolls, okay? And this is the amazing thing about it. We want to stop progression, regenerate hydroxyapatite naturally that occurs in the mouth, and have a very high success rate with it. And now what we can track is, especially using AI caries detection with Pearl second opinion, to look at that either regress over time or the lesion staying the same. I'm happy either way. Yes, I would love radiographically to see a big change for all my lesions. It doesn't happen. But however, I'm watching these lesions, and this is why I'm so passionate about it, is I used Curodont for a time in my practice till I started seeing recalls back before I really bought into it. And then, again, I just put it on some of my children. Okay, so I want to thank everybody for today. I want to just let you know about 2 courses that I'm doing that directly involve, especially this one. This is one of the first, or I believe the first, combination class for ortho and pediatric dentists to come together. The whole idea of this is bringing that orthodontist, and maybe the orthodontist wants to gift that to their main referral. And we talk about these concepts, not only of restoring teeth, minimally invasive treatment for white spot lesions. Sometimes we have to use composite. If we can put processes in early, like I have with my orthodontist, where he sees white spots, he alerts the office, we bring that patient in right away and they get Curodont. But this is going to be a 2-day course. These are a lot of the concepts we're going to talk about, along with peg laterals and restoring teeth and treatment planning with orthodontics. This is just quickly about my course just for pediatric dentists. And you can reach out to me at pediatricdds.com. And lastly, that is my contact information. So if I know this was a lot of information about 3 really distinct products and procedures all together. So I tried my best to get this done in time and get it all together. But if you have questions specifically about anything we talked about today, or you want to send me radiographs, discuss something individual with a patient, please do so. So I have multiple email addresses, joshua@pediatricdds.com or joshua@bioclearmatrix.com, or you can also scan for my QR code there. And I think we're going to turn things over here for questions that we had during the webinar. Thank you so much.
Thank you so much, Dr. Solomon.
That was a lot of information we had to pack into one webinar.
That that really was, but it was great information. Thank you so much for
You are welcome.
giving that wonderful presentation. Now is time for our Q&A. So if you do
Great.
have any questions, make sure you use your control panel now on your screen to ask any questions. And I will be happy to moderate
Great.
that.
And are you going to pull these ones up that people typed in and you'll ask me? I'll let
Yes.
you. Okay, great.
So those courses that you, while questions are coming in, those courses that you offer, or any of those, are those all hands-on, or can people
Oh, they
attend
are, no, these
digital?
are, I do one virtual year, but these are all hands-on. So
Okay, got
really,
it.
I think very apropos for this discussion today is
Mm-hmm.
we spent a lot of time here talking about, unfortunately, with white spot lesions and
Ah,
how to treat caries and setting up a process between the orthodontist and pediatric dentist, not only for that initial referral, but how do we see, we have this down to science with my orthodontist. He sees the white spot lesion, they take
mm-hmm.
a photo or they call my practice. We get that patient in right away. They get emailed information about Curodont from the very beginning, videos, so the parent can review all that before he gets to the office. And typically, they don't even book the appointment unless they really want to proceed with Curodont. Patient sits down in the chair, treatment plan signed. It takes me just minutes per tooth, and that the access and the ability to diagnose and treat early on has
Mm-hmm.
been amazing, because we know that if we don't change hygiene and be able to treat these teeth in a minimally invasive fashion, ortho is going to come off and they're going to look like this patient there, where
So
there's
what
just
if
holes in the
ortho
teeth.
refers to you, they refer to you, and then say they print out the paper, they give it to the parent calls, makes the appointment. What's that chair time look like just for the biomimetic, application?
Just we're talking, I mean, maybe a 20-minute appointment, and that goes everything from them signing the treatment plan to the patient
Right.
leaving, right? Because the Curodont
Awesome.
is really 3 minutes per tooth. And we have already sent all the information about Curodont ahead of time. So what I find is that my acceptance rate is almost 100% because the parent already
Right.
has all the information. So they're not
Mm-hmm.
even going to waste their time or our time. I mean, I wish they would come in to do this, but they're
Mm-hmm.
not going to show up unless I've thoroughly explained this. We've explained this via the
Mm-hmm.
videos. I mean, there's so many handouts and videos available. And they come in, they sign the treatment plan, they already know what's going to happen that day. Curodont supplied, 3 4 minutes a tooth, if that, and then we move on. So,
And
and
the
the other thing
dentist
is
doesn't even have to worry about selling it. It's already
correct. Yeah,
sold.
because I don't
Yeah.
want to sell it. I just want them to believe in. And when I tell them
Right.
this is what I've done for all my children, that
Yeah.
helps quite a bit as well.
Love it. Okay, I do have some questions that come in. So,
Please.
what are the most common false positives with AI caries detection, and how do you clinically validate them?
Yeah, that's a great question. So I tell you, we know that AI is getting better and better and better, right? So I've seen huge improvements in the diagnostic accuracy of Pearl. It was always good, but more and more, I think things are changing the engine where it's even more accurate. The important thing is garbage in, garbage out. So if you take bite wings that are all overlapped, the AI it will do better than in your natural eye, I believe, than with overlap. But you've got to have good images to start. And, these are diagnostic tools. They are not, a screen is not popping up saying, drill a hole in this tooth or put Curodont in this tooth, right? It is just part of my diagnostic ability. So I'm using the radiograph, I'm using the AI caries detection, I'm using that transilluminated image or fluorescence. So I'm not worried about false positives because I have so many tools instruments at my disposal where I'm pretty accurate. If I thought I was decently accurate before just with the radiograph, now I have all these instruments at my disposal. I don't think I know there's not a mixture of technology today that's going to give me any more accurate results. There's not.
Okay, awesome. And if AI flags a lesion, but transillumination shows no clear shadowing, would you treat or monitor, and for how long before
Yeah,
reassess?
good question. If I have to think twice that there is caries there, and often we forget too, don't be an occlusodontist. What do I mean by that? If you see an interproximal lesion there, often if you've got magnification on, you can also dry that tooth with air and look. And if you see decal, which often you can, racing into that contact is getting cured on. I don't have to think about it, right? So I really believe that between just the AI caries detection alone, it's picking up lesions before I could even see them with my naked eye. Again, I think it's important for people to understand your eyes can see maybe, 30, 60 shades of gray. The computer's seeing thousands.
Okay. And so if a patient has bilateral lesions, would you intervene immediately or attempt remineralization first?
So bilateral, I think what the doc's discussing is maybe teeth that are touching, is if I don't have, we have to make a huge hole to get to those carious lesions, especially teens that I see. Most of the time, I see a lot of I don't see a lot of occlusal caries because we're sealing a lot of teeth, but I see teens that may have 8, 9, 10 of these back-to-back, interproximal lesions. And if there's decalcification there, I just had this discussion with my associates. If I know there's a medicament that has a high success rate of recalcifying that tooth, it's my job now to not perform supervised neglect, right? I need to give the parent the option, right? Here's what I see. There is, an E1 lesion on both of these teeth. They're touching, and let's make a decision together. Now, if they're if they're 15, it's the very first tooth that they've ever had caries. I may not be pushing Curodon as much because usually that may be slower growing. But if at 13, I'm starting a lot of interproximal class 2 lesions, this E1, maybe E2, it's my duty to tell the parent there is a minimally invasive way we can let your tooth, heal itself naturally after putting a compound in there using your own minerals from your own saliva. And if they don't want to do it, that's up to them, right? I can't make the decision for them. I can just lead them to water. I can't push them in it, right?
Right. Okay, and how do you avoid overtreatment in cases of a stain versus true subsurface
Oh,
demineralization?
I love it. That's where fluorescence and transillumination is amazing, right? Because we see these teeth occlusally, and is it a stain? Is it caries or not? So I have, all the tools and toys. I've got a diagnocam, I have a diagnodent, and I'm using magnification. And those are very, very accurate tools, right? Actually using that bacterial using the fluorescence, picking up those porphyrins and bacteria, and you can actually see with color, is this arrested or is it active decay? We just didn't have that technology before. And now I've got a device that can do all three at one time: photo, transillumination, and the fluorescence itself.
That's awesome.
I'm not guessing. I don't want to guess anymore.
Love that. How do you balance aesthetics and efficacy when choosing between SDF and remineralization protocols?
That's a great question. Typically, primary teeth, and it's just honestly a matter of cost because SDF is less expensive to buy. But if I do have, more and more, I'm offering Curodon primary teeth if parents are worried about, if they're worrying a little bit more about aesthetics. I find that most parents, if they are happy with the SDF, but I now have all, as my teenagers say, all the things, right? I have all the options. So you want A, B, or C? Do you want SDF? Do you want Curodon? Do you want nothing and just come back for more frequent exams? Or do you not want to listen to me at all? You've got all the choices. I have the most accurate diagnostic ability with all three of these components. And my job is just to educate. They can decide what they want.
Okay. How do you manage compliance challenges in pediatric patients when treatment relies on behavior-dependent remineralization?
Yeah, that's a great question too. A lot of it is honestly getting the parents to buy into things, because if you have a mom and she has 4 children at home or 3 children at home, I see this sometimes in moms all day, right? They have their coffee in their hand and their face is just strained because they've heard the word mommy 27 times in an hour, right? And so what we really, you may know this, one of the big things we do is these brushing, flossing calendars, right? So I try to get the child to initiate and asking their parent for help instead of mom running or dad or mom's running around the house, to, try to get their child to brush and floss their teeth. So these calendars have 4 spots per day: brush, floss, mouthwash. And then I have the child do the checkoffs and they put a little star if their parents help them. So I try to make it really put that onus on the child. And then they're building those memories in their head. Well, I better do this every single night. So when they're not, 17, and don't want to listen to anybody, the parents have to, text them to say, go floss your teeth, right? They just do it.
I don't know. My son's 12 and I'm still yelling at him to floss.
Exactly. Well, exactly. Right. So we need to put the onus on them and try to do it earlier.
Well, thank you so much.
You're welcome.
We have run out of time, so if there are any other questions
Sure.
that have come in,
Please reach out to
um,
me.
yeah, absolutely. We will make sure that you get a response via email. And then also Doctor left his contact information. So we will definitely get to your question if we did not get to it tonight. So thank you everyone for your questions.
Thank you so
And
much.
I do want to remind everyone that in about an hour, we will send you a link to access this course. And then just make sure you fill out your survey and then you will receive your CE certificate. And also, of course, we want to thank our sponsors, Vivardis, Cavo, and Pearl. Thank you all. And
Thank you.
especially thank you to you, Dr. Solomon, for joining us.
Thank you so much. I want to thank everybody from Spark and have a great rest of your day.
Thank you. Take care.
Take care. Bye.
We hope you enjoyed this presentation of Spark Study Club. You can receive CE credit for this lecture by visiting sparkstudyclub.com. Thanks again for listening, and we hope to see you again soon.